There'll be a question and answer session, and you can submit.
Present to everyone about the clinical uses of the ATOP. So my name's Nick Lintzeris. I'm the Drug and Alcohol Director for South East Sydney Local Health District and also a Conjoint Professor at the University of Sydney. We've also got Christine Mammon, who is the project lead for the COQI project, and she'll be helping us walk through some of the questions and discussions at the end. Hopefully if I can keep on time, we'll get through the formal presentation in the first 30-40 minutes, hopefully, and then hopefully there should be sufficient time for a bit of questions, discussion, and general learnings. So what are we looking at achieving today? So the learning objectives, hopefully by the end of the session, you'll have an understanding of the broad applications of the ATOP in clinical settings, and in particular, how we use the ATOP as a clinical screening and brief assessment tool, how we use the ATOP to develop care plans and to monitor the progress of clients, people in AOD treatment, how it can help us to standardise communication between services and between service providers. Oops, jumping ahead. And also how the ATOP really fits in assisting services to deliver the New South Wales alcohol and other drug clinical care standards. As you're all aware now, so for the last year or two, we've had the New South Wales clinical care standards have been endorsed. And really, they set the framework for the processes in how we provide care for clients. So you can see there are the clinical care standards. There's standards around intake, around how we do comprehensive assessments, how we do care planning, risk identification and response, monitoring treatment outcomes, and then also transfer of care. So the ATOP can be used in each of those standards, probably with the exception of intake, where intake services tend to have their own processes around intake. So what is an ATOP? You can see there what the ATOP looks like. It's not great visual, but we'll tell you where you can get more information and get the actual copies downloaded. So the ATOP really is a tool that we use in clinical assessment and risk screening. So it's important that I really want to emphasize that the ATOP really is a clinical tool, and it is designed and used to improve clinical care. It was never designed to be a research instrument or primarily for the purposes of evaluation. However, it can be used for those purposes as well. Whoops, I seem to be on an auto progress slide, so I apologize for that. So we can be using it for evaluation purposes. And in the evaluation literature, you'll often see a lot of talk about what they call patient-reported outcome measures. Now, a patient-reported outcome measure is an instrument or a scale where the response is directly from the client. So it's whatever the client says about how they're traveling in response to an item. So it doesn't need clinical interpretation. That's an important sort of feature of what a patient-reported outcome measure is. So importantly, the ATOP is an opportunity to hear from our clients how they see themselves traveling across a range of domains. Now, the ATOP should be easily incorporated into routine clinical care. It does have 21 items, and it takes about 5 to 10 minutes to administer. It can take longer for clients with lots of issues going on who like talking a lot, but in general, 5 to 10 minutes is pretty standard in terms of administering an ATOP. It can be delivered either face-to-face or, importantly, in the time of COVID, it also has been validated for administration by telephone. So that's really important, that we feel confident that the ATOP can be, as a reliable instrument also for telephone administration. And it was really developed for use in community settings. And what I mean by that is really sort of for outpatient settings, where often, appointments are time limited. They may be 30 minutes or up to an hour. And really highlighting that when the ATOP was developed, it was actually an adaptation of the British TOP, which stood for the the treatment outcome profile, and we adapted it to Australian conditions and became the ATOP. So when it was developed in the British context, it was very much in that sense of we needed a scale or we needed a tool that can actually assess a broad range of substance use and related health issues and social issues, and that could be easily administered in a standard 30-minute, one hour kind of an appointment. And I think that's an important distinction of the ATOP, because there are a range of other scales that we can also use. And indeed, often we have a battery of instruments that we can use that assess different dimensions for a client. So, for example, the K10 is frequently used to assess psychological distress or mental health, and that's a great scale. We love it, but it's 10 questions. And then when you start adding other scales that address other things like social well-being, quality of life, substance use, when you start to put all those scales together, they can actually start taking up a lot of time to administer each of them. And that's really one of the advantages of the ATOP. It is one scale, 21 questions, and it broadly assesses a range of health and well-being as well as substance use issues. Now, what I'm going to be presenting today is really an overview about what the ATOP is and how we apply it. It's not really a training program on administering the ATOP, but what I will do is refer people to these websites. So both you can see them there, the www.aodatop.org and the www.aodcoqi.org. Oops. At that, on those pages, you'll find a whole range of resources that relate to the ATOP, including training packages for clinicians on how to administer the ATOP. And also there's quite a comprehensive training manual as well, a written version, which also goes into much greater detail about administering the ATOP. So I'd refer everyone to go and have a look at those web pages, and there's a lot of resources there, as you can see, and also a lot of information around the clinical care standards and so forth. Or you can contact the COQI team that Chrissy Mammon heads up, and that's the website there. Okay, so as we said, the ATOP 21 questions, and what is it that we ask about? The first 10, 11 questions relate to substance use in the previous 4 weeks, and we use sort of like a modified timeline follow-back technique, where we ask people about, tell us what's happened in the last 7 days, the 7 days before that, the 7 days before that, the 7 days before that, and that allows you to develop up a profile over the preceding 28 days. And it asks for all of the more commonly used substances in sort of Australian clinical settings. So there are questions around alcohol, cannabis, amphetamine type substances, which includes, in this context, MDMA, benzodiazepines. We generally get people to report both prescribed and non-prescribed benzodiazepines. Don't really try to put too much effort in an ATOP in separating what was prescribed or not prescribed, simply because often there's so much fluidity for many patients in terms of, well, for many patients, they may use what was their prescribed, but they may use either different amounts or sourced from other sources. So really the benzos, we're asking about the total amount used, irrespective of the source of the supply. Heroin, other opioids. With the other opioids, we do not include the use of methadone or Suboxone that is prescribed for the patient. If a patient is buying illicit methadone or illicit Suboxone, then that gets counted, but not if it's prescribed methadone or Suboxone. We've got cocaine, we've got opportunities to write in other substances, and also we have tobacco in there as well, and the tobacco questions are also asked in a similar way that we can also then record the average amount used. Now, when it comes to the average amount used, we have some standardized approaches for alcohol and cigarettes. So alcohol, you do standard drinks. For tobacco, we do cigarettes per day. For the other substances, we all know there is no standardized approach to documenting heroin use or ice use or cannabis use. And different clients report different ways of they will use a different way of describing their use. So a cannabis user might talk about how many grams they use or how many bongs they use. A heroin user might similarly talk in terms of, caps or grams. Some people might talk in terms of money, the money spent. So generally what we suggest is whatever the client is, however the client reports their average use, you document that, because chances are when you repeat the ATOP a few months down the track, you can use a similar language or a similar way that the client had reported it, and allows you to then look at changes in quantity as well as frequency. So I think many of us working in this sector will be aware of the diversity on how people report substance use practices. We also have a role there for injecting and also for bloodborne virus risk practices around injecting. And it's a really simple question whether or not you have used any equipment used by anyone else. And so those are the substance use questions in the last 4 weeks. Then we have a range of health and wellbeing questions. The first two relate to days employed and the days engaged in study, and they're asked in a similar timeline follow back. There's a number of yes or no risk questions around housing, violence, arrests, and child protection. And then we have 3 questions which are patient-rated health status, using a 0 to 10 scale, where 0 is poor, 10 is good. And we get clients to rate themselves how they feel that they've been traveling with regards to their psychological health, their physical health, and their quality of life. And there's some definitions in there and what we mean by that. Now, we've gone and done a lot of work to look at how the ATOP scores on these domains compare to some commonly used other scales. So, for example, many of you will be aware that something like the K10 has some cutoffs, at which point, if you score below a certain amount, then that suggests to us that you've got some concerns around your psychological well-being. And we've gone and done the similar kinds of work to look at comparing ATOP scores to those other gold standard scales for each of those 3 domains. And generally, what we've been able to do, that if a client rates themselves as 5 or less, then that generally means poor health with regards to that scale. And if it's 6 or more, then that's generally considered good health. Now, we all know these are somewhat artificial, these constructs, these cutoffs, and everyone rates themselves slightly differently, but it gives you a bit of a gauge as to where the client's traveling. Clinically, the way I would follow up with one of these, if a client rated themselves, say, as 3 out of 10 for their physical health, then I would follow that up with so tell us why you've rated yourself as a 3 out of 10, because that suggests that you've got some concerns. What are those concerns? And that allows us then to pick up what some of those issues are around their physical health. So it's an opportunity to start identifying what are the issues for you in these 3 domains. So they're the key questions. And again, I'd suggest go look at the ATOP training manual and the training package on the COQI website. Okay, so how do we use the ATOP? Clinically, we use it in 5 main ways. We use it for brief structured assessments. We use it for risk screening. It can help us with care planning. It can help us for routine monitoring of client outcomes and risks. And it also allows us to communicate between ourselves and between services using a standardized language. So they're the 5 reasons why clinicians should be thinking about using the ATOP. Now, service managers and researchers and quality improvement officers can also start thinking about how they may use the data from an ATOP for service evaluation, quality improvement exercises, and things like that. Now, we won't be focusing on that today, but there's a future webinar that we'll be using. We'll be walking through some of those, and I'll tell you about that in a moment. So let's look at the clinical applications of the ATOP. The first area is conducting a brief structured assessment. Now, we all know that a good comprehensive drug and alcohol assessment, which is one of the clinical care standards, we all know that routinely takes a good hour to conduct, sometimes can take even longer. But we don't always necessarily have a full hour or 90 minutes to do the full comprehensive assessment. And sometimes we find ourselves running out of time, either because, we're busy, or the patient turned up late, or other things have come up, or the client likes talking a lot, and what would have been a 1-hour assessment, you need to do over a couple of sessions. So one of the advantages of an ATOP at the beginning of a structured comprehensive assessment, it allows you to quickly touch on all the key issues early in the assessment, because it flags some of the things that you may want to touch on or may want to get to during your first assessment. So for example, if a client identifies that they've got, say, domestic violence or housing issues, yet your standard clinical assessment may not get to that until the second half of the assessment, and if you've run out of time to follow up on domestic violence or housing, it may not be appropriate to say, oh, we'll finish your assessment next week. Meanwhile, the client is going through those social problems, and you don't really want to defer that for a whole week. So that's the advantage of an ATOP. You can quickly, at the beginning of the assessment, just quickly run through, look, broad overview about what drugs you're using and what are the key issues going on for you in your life at the moment, you know, in particular with some of the risk issues. So you can get a quick sense of what do I need to make sure I get to in this assessment, and what can I maybe leave for, you know, filling in the fine details at a later time. So that's really important in terms of helping us do the sort of a structured assessment. There's also times when we actually don't have time to do the full 1 hour comp assessment. If you're out there doing outreach, if you're in a CL role in a clinical setting, there's lots of opportunities where it's just not appropriate to sit down and do a full 1 hour comprehensive assessment with the client. And that's where, again, an ATOP can be a quick assessment, quick sense of what's going on, and you're feeling confident as a clinician that at least you've asked about all the key stuff, especially from a safety perspective. So that's a key function of the ATOP. Similarly, often we find ourselves where, you know, the reality is that often we end up having to change clinicians during a episode of care. And sometimes, you know, what we find, it can be really, really useful in this sort of handover from one clinician to the next. So either the clinician, you know, about to hand over can do an ATOP before the handover, or what I find really nice when I'm taking over a new client is I can actually just say, look, first time I'm meeting you, let's do one of these ATOPs, because you'll just give me a quick snapshot of what things, you know, what's going on for you at this point in time. So it's a nice way of just being able to get a quick update on where the client's up to. It's also really good, and I found this as a clinician, that we're all busy. We all end up taking shortcuts in our clinical work, and you have to. And that's, you know, because often you'll be working with a client and you know the issues with the client. It may be their amphetamine use and their mental health issues. And that's the thing you focus on time after time. But if you don't ask about some of the other issues, then things may have changed and you haven't picked up on them. So that can be one of the nice things of just sort of doing an ATOP from time to time, because it sort of takes away the assumptions or the blind spots that we have. You know, oh, this guy's a drinker, he doesn't use other drugs. Well, that might have been the case when he first presented, but it may not continue to be the case. So it's just an opportunity every now and then, just let's make sure that we're covering all the issues here. So that's how we sort of can use the ATOP for a brief structured assessment. Now, the other thing that the ATOP does has lots of questions that are really pertinent around important risk factors: homelessness, violence, child protection concerns, and any mental and physical health concerns. So again, the ATOP has questions around those. And if a client identifies any of those, then that means, you know, don't just ask, but do something, follow up, because the client's identified a risk, and that generally means you're going to have to go in and do a little bit more assessment as to what's going on here. Having all these questions also as a structured interview allows us to sometimes raise sensitive issues. So we all know, raising issues around violence, child protection, some of those questions can be sort of really sensitive, sort of like, well, why are you asking me this? Are you calling me a wife beater or something? So again, you can just say at the beginning, look, this is a structured assessment. We ask all our clients these questions. Don't take it personally. Look, it's a checklist. See, here they are. I'm going to ask everyone these questions. So it's a way of being able to just introduce those topics in a way that, you know, without sort of somehow implying that we think you're one of those people. And the opportunity, again, to follow up over time, because risks do change over time. Now, in terms of what do we mean by responding to the risks? So you'll find in the ATOP manual, we've got lots of these kinds of guides. So again, for each of the risks that we've got identified here in this PowerPoint slide, you can see what's the risk, how do we identify it in the ATOP? So how would you pick it up in an ATOP? Now, sometimes it's really obvious. Homelessness, we've got questions around it. So that's really obvious. But some of the questions you actually need to put your thinking cap on. So something like overdose risks. So if you've got an individual that is reporting lots of sedative use or, binge patterns of drug use, where they may not be using a drug for a long period of time, and then, no benzos for 3 weeks, and then they used a pack of 50 Valium in 2 days. Those things should start raising concerns about, well, are you at a risk of overdose with that pattern of substance use? So that's how we might identify a risk is there for a client, and then what some of the recommended responses might well be. And often it's a case of, look, dive in further, ask more questions, get a sense of what's going on for the client. Care planning, again, really essential in AOD treatment. And we do care plans at the beginning of a treatment episode or a treatment encounter. And this is really at the beginning, as part of the ATOP, you've sat down, you've walked through all the key domains with the client, what their drug use is, what some of their health and social issues are for them. And that allows you, when you start doing the care plan, to sort of align the issues that were being raised in the ATOP and other parts of the assessment, obviously. And then you can ask clients, so, okay, you're using cannabis 25 days in the last 28. Do you think that you've got any issues arising from that, or do you have any concerns? Have you, what are your goals around your cannabis use? So it allows us to start using the information from the ATOP to allow us to do the initial care plan. Then we've got the opportunity to use the ATOP along with, when we review the care plan. So it might be 3 months later, and you sit down with the client to review the care plan, and generally what we recommend is do another ATOP. Because what the ATOP allows you to do is then look at basically the question of what's changed over time, and is the client now achieving their goals? And also allows us to say, well, where client is achieving their goals, you can highlight the successes. Look, well done. That's great. You've done really well. Let's keep going. Let's do more of whatever you've been doing that has allowed you to achieve your goals. But it also allows us to look at where a client isn't achieving their goals, to then say, okay, well, you had planned to reduce your cannabis use. You thought you were going to do it in this way. You set a goal that you wanted to reduce your cannabis use from 25 days to half of that, to 3 days a week, 12 days in the last. But, we sat down, we did the ATOP, and you haven't really budged. The way we developed the plan last time was that you're going to, go and do X, Y, and Z. Doesn't seem to have helped you to get where your goals are. What might plan B look like? So what else can we do in your care plan to help you achieve your goals? Or do we need to rethink the goals? So having that kind of opportunity to monitor clients against their goals over time really, really can be important in terms of the care planning. And of course, goals change over time. That's really important, that the goals that a client comes in on treatment with hopefully change over time. And that's generally considered good, that, as clients progress in their recovery, that they start setting higher goals and wanting to achieve more and more and more. So goals do change, and we need to keep reviewing the care plan over time. So here's a way, and look, it depends, if you're using EMR, which is the New South Wales Health System, you can do this electronically, but there's, you can also do this just physically by getting out the last ATOP and this current ATOP and look at how things are going. And it also allows you to draw links for patients. So this is real data that came from a client where you can look at cannabis use and psychological health on the left. And it really allowed our counsellor to then sit down and help the client understand, well, look what's going on here. As your cannabis use reduced, your rating of psychological health seems to be improving. And the example on the right is the opposite, where again we've got the alcohol and physical health, so a similar kind of pattern. But you can mix and match the items that you're going to compare in lots of different ways. You might be interested in, for example, that someone's heroin use when they enter an OTP program might reduce, but you notice that their, say, cannabis use increases. So again, it allows you to start linking different things in the client's well-being and overall health around their substance use and different dimensions of care over time. And this feedback to clients is really, really powerful. We know this in lots of areas of healthcare, that providing feedback to clients, a lot of clients really, take that value, really value that, to be able to see, how things have been changing over time. Another really important point, I think we're all appreciating now that we all provide care for our patients, but increasingly, clients move between services, and they often have multiple service providers at any one point in time. The days of, a client only goes to one service and they get everything done in that one service is kind of not really Australian healthcare anymore. And that, our clients are often seeing multiple healthcare providers and social welfare providers as well. DCJ, there's lots of people involved with our clients, and clients often move from one to another, from one service provider to another. So we've actually found the ATOP really useful as being able to assist in that kind of handover and to provide a common language for different teams and different clinicians to be able to talk to each other. And of course, the ATOP is really, really useful to be able to incorporate it in any transfer of care documentation. Okay, so they're the clinical care standards. There is the evaluation and quality improvement. Rachel Deacon, who works as part of the COQI team, is actually going to be running another webinar in a couple of weeks' time, which actually helps people sort of look at how do you get all this information, which we've either entered into our medical records or into the into the computer. How do you go about sucking it out of the computer and using it to be able to report on who are your patients, what do they look like, or who are your clients, what are their characteristics, what are their patterns of substance use and their health issues and their social issues when they first present, and how the things change over time, and allows you to really sort of look at different kinds of information from your own services, and really important for quality improvement and clinical research. But if you're interested in then how do you use ATOP data for evaluation purposes, I suggest join that webinar. There's also a manual that we'll be releasing on the COQI website around that very soon, in the next couple of weeks. Okay, so I am on time. Fantastic. So summary of the learning, the ATOP, as we said, has got multiple clinical uses in a clinical setting. Many of these allow us as clinicians to be able to make sure that we're fulfilling the clinical care standards for AOD in New South Wales. And really the advantages of the ATOP is its ease of use, simplicity of use and scoring, and the brevity of it, with one instrument that allows us to really provide a snapshot of the range of issues that confront our clients. I just want to acknowledge the people that have been working on the ATOP, really going back since 2009 is when we started doing this work. So that is now 12 years of work on developing, researching and validating the ATOP. They're some of the key players involved. And of course, we want to acknowledge New South Wales Health, the Centre for AOD, and prior to that, Medeo, because they've been strong supporters and have funded much of this work. Okay, so that's the formal structured part of my presentation. It's not often you get me to stick on time, so I've done really well. And that provides us an opportunity to throw it open to questions. I'm going to stop sharing. So there we go. And hopefully you can see Christy and me in person.
Thanks so much for that, Nick. So we'd just like to invite you, if anyone has any questions, if you can use the Q&A function down the bottom of your Zoom browser. We've only got one comment at the moment, and it's Andrew from Vinny's CCC program saying hello to us. So hi, Andrew, how are you? But we just might give it a few minutes then just to see if any questions do come in.
I mean, one of the things that, so whilst questions might come in, one of the areas that we found the ATOP was really useful in our COVID responses. So in our COVID responses, and I'm sure many services, other services in AOD, in health, think about the changes that we've had to go through. We've had to move away from seeing our clients face to face and move a lot of things onto telehealth, where historically we would have been following up with clients often in person, and you've had the opportunity to do those talks. Now, often what we're having to do is a lot of telephone work where you might have, a clinician basically spending several hours ringing clients up, just touching base, how things going with you and so forth. But what we're also finding is, how do I put this? COVID is also disrupting our staffing profiles. And I'm sure many services will understand what I mean, that the staff you have working this week may not be with us next week. They may have to have been in isolation. They may have gotten seconded to a vaccination clinic. So we're finding disruptions in continuity of staffing as well. And so that's where we found, again, the ATOP can be really, really useful in doing a lot of that touching base with clients, how you're traveling. Again, it's a quick way of making sure they've got not just what are you doing about your drug use, but also touching base around some of those really important things around, violence, housing, all those kinds of things, picking up on what's happened to your work, all those kinds of things are really, really important. And just, how clients are traveling with their mental health. So we've actually found that the ATOP has been useful in our COVID responses, particularly in areas like opioid treatment, where we had to make lots of decisions around takeaways for clients, and we needed a way of documenting our risk assessments. Why did you give that client 6 takeaways, but that client got none? So a way of being able to have a consistent approach to that is also being able to do things like using an ATOP as part of that risk assessment process.
Thanks, Nick. We've got a question here from Susie. Thanks, Susie. Hello. She's asking, have we found it useful to use ATOP scores in supervision with staff to encourage them to use the information to inform their clinical work?
That's a really good question. Probably a couple of ways to think about that. So first of all, I've got to acknowledge I don't do clinical supervision of staff. So I'm not a qualified supervisor. So I'd have to say that, and different supervisors have different approaches to what they do in supervision, and also will vary on whether or not you're doing one-on-one or group. So I think the nature of supervision varies a lot in with different professional groups and different clinical settings as well. But certainly, we often will use it. If I say maybe not my meaning of clinical supervision, but say the complex client review, where you may have a multidisciplinary team, or you just may be a clinician with their supervisor or, manager or whatever. And we're an opportunity to present a really complicated case. And again, having an ATOP there is a way of being able to sort of, again, engage with the clinician. And so what happened over time? And again, so you've been doing what with this client and how did that work? So it does allow you, again, just to do that kind of ongoing monitoring around an individual client. And we certainly incorporate our ATOP scores in some of those complex case reviews. The other approach, though, also is thinking of it more as like a quality assurance sort of activity, that idea of supervisors or managers being able to look at how well are their team going in things such as, have all our clients got a care plan? Because we're supposed to do them with our clients. And I think it is an important sort of aspect for in terms of managing services, that you can actually go and see, well, what proportion of your clients have got an active care plan at the moment? What proportion of your clients have had an ATOP done, or getting discharge summaries done within the allocated time frame as per the clinical care standard. So it is a way that we can use the ATOP for that kind of service evaluation management as well. But again, that's really more, Rachel can talk more about how we do that. So the ATOP can have that use as well. But that's not really a direct clinical application, if that makes sense. I'm not sure if that's adequately addresses that, because
I'm just going to add, though, I'm aware of many teams that just routinely report the ATOP scores in their multidisciplinary case reviews. So they'll start with the ATOP as kind of setting the scene as to how recently someone's had one, but also using that clinical information to really briefly communicate who the client is.
And so I was just going to say, in New South Wales Health, we have this thing called ISBAR, which is a structured approach to handover from one clinician to the next. This came about a few years ago across New South Wales Health, because when anyone reviews problems in healthcare, I mean, most problems in healthcare where things have gone wrong with patient care tend to actually happen in the transfer of care between clinicians. So usually it's not that a clinician has done their job badly or that they don't have the skill set. Usually things go wrong in clinical care because it wasn't handed over to the next person or to the next team, or a referral was sent, but no one ever followed up. Did the client ever follow up? So it's often the handing over from one clinician to the next where things often go wrong. And that's why handover became a really big focus of sort of quality improvement activities in healthcare over the last 5-10 years. And part in New South Wales Health Services, that got structured with the mnemonic of ISBAR, but it's essentially, as Chrissy said, it's a way of being able to say, who is the client? What are the issues that's going on for them? And so the ATOP is a nice way, again, of just standardizing the way we communicate between clinicians.
So we've had another question. So can the ATOP wellbeing ratings be equated with more detailed and similar measures like the K10, or is more research needed to establish this?
No, look, really good. Really great question. So one of the ATOP, we've validated this now on numerous occasions. It's been validated by telephone with alcohol and opioid users. It's been validated in alcohol and opioid users on numerous occasions, cannabis users and methamphetamine users. So we're feeling pretty confident that across the types of substances that get used by many of our clients, and also that setting of face-to-face and telephone. And yeah, it has been validated numerous occasions, pretty decent validity, that a single question on an ATOP, say for physical health, quality of life, or psychological health, does match pretty well to a K10 or a HUQOL or a OSQOL for quality of life measures, SF30, a whole range of all these kinds of scales that we validated against. And if you want to see the details, they're all on the COQI website with all the publications and so forth. Now, there's a single question: how is your psychological well-being? Is it as good as a K10 with 10 questions? And the answer is no, of course not. A single question isn't going to get you the depth of information that a 10-item K10. And a 10-item K10 is not as good as a DAS21, which has 21 items, which then actually allows you even more sophisticated sub-analysis. A K10 just gives you a broad psychological distress. There's a bucket of distress. A DAS21 allows you to say, this is more depression than anxiety or stress related. So the more advanced and complicated your scale, the better the information. That's axiomatic. We know that. And we would not say that a single item, ATOP, rate your psychological health, is as good as a K10 or as a DAS21. However, and it really gets down to, look, if you've got an hour to spend with your clients doing all the broad range of questionnaires, then they're great. They're great questionnaires. The ATOP is the brevity that really allows us to use it routinely in a wide range of applications. So look, a single item is not as good as 10 questions, and 10 questions is not as good as 21 questions. We see it, for example, with general health questionnaires. We can either ask a 8, 9, 10 question item, like the Euro HUQOL, which is 8 items. It's okay. It's not as good as the full HUQOL. The Promise 9, it's okay, but it's not as good as the Promise 29. So the more questions you ask, the more information you get.
Thanks, Nick. And really along that line of the time it takes to ask questions, we've got a question here: timelines for inputting data with key performance indicators and reporting requirements can create urgency and stress to get it done. And there's been some suggestions that we should be doing the ATOP without the client on their behalf. But I'm concerned about the accuracy of the client's information and data. So what would you suggest in this scenario?
So the ATOP was never designed to be completed by a clinician on the client's behalf. That is not the ATOP. That is a clinician-rated understanding of what the client said or just believes. And that's not the point of a patient-reported measure. So the ATOP is to be it is about capturing the client's responses. Now, sometimes the client tells you things that you think to yourself, that's not right. And there are ways, and we sort of walk through this in the manual, about how sometimes you may need to repose the question to help the client understand. Sometimes they misunderstand the way we've asked the questions, and sometimes it can just be, oh, is that what you meant? So often we find things like the rating scales of 0 to 10. Sometimes you have clients rating it in the opposite direction. And you kind of think, hang on, you've just rated yourself as you're doing really, really, really poorly. And yet you actually have been telling me you're doing really well, because they've just got the numbers wrong. So sometimes you do go back and just check that that's what you meant. Did you understand the question properly? But no, it's a scale that requires the client to provide us feedback. As for the when do you enter the data? So when we first started using the ATOP, it was not part of an electronic clinical record. It was pen and paper. And it was not very satisfactory in terms of clinicians would fill it in because they were using it clinically, but then it sat in a paper file. And then it had to be either the clinician had to go and enter into a database. Guess what? They didn't. Why? Because they get busy. Or you hand it to admin staff to enter into a database. And guess what? That didn't happen on time either. So anything that requires double handling is never going to be as efficient or as real time as if you can do direct entry. We're lucky in New South Wales Health that the ATOP has been incorporated into our electronic clinical record. And I'm aware that many NGOs now are also incorporating the ATOP into their sort of clinical information systems where they have them. But there's a lot of diversity, is my understanding, on how different NGOs collate their information. Certainly, if you reach out to the COQI team, they certainly can assist in terms of providing versions of the ATOP that are, Excel friendly and so forth. Microsoft Access. So we built this originally in Microsoft Access because that was a platform that everyone had and you could build it and so forth. All that's available in New South Wales Health, though, it's been built into our electronic medical record system. And I would strongly urge that if services were really keen to do this, that they would think about, are there ways that you can do this so that it's real time, so the client tells, you ask the question, the client gives you the answer and you complete it there and then. We are keen to look at a validating self-completion of an ATOP, the idea that you might mail it out to someone or give them pen and paper and say, here you go, fill this out, or to have a web-based, but we haven't been able to get around to doing that work, partly because of funding, and also partly because very few scales have actually ever been validated for self-completion with our client population. And one of the real problems there is the high rates of poor literacy and the high rates of cognitive impairment and the frequency of intoxication with our client population. So, yeah, I think many of us are aware of some of the challenges in client completed scales. Look, many people can do it. Most people can do it, but we do struggle that there is a population of our clientele, 10, 20, 30%, that really struggle to be able to reliably complete these kinds of instruments.
Yeah. The next question we have is about visualizing the ATOP results. So do we have any advice or opinions on which graphs or figures work best for clinical work with clients as opposed to research and evaluation? This is such a great question. I don't know if we have the answer, but...
Well, so look, I must say that within our electronic platform system that we use in New South Wales Health, so most of us use a thing called EMR. Unfortunately, the visualizations are pretty ugly. So you saw the way that we can present information to clients using our EMR. It's not very pretty. It's not very pretty at all. But I've seen other people who can actually then go and use their own software to be able to provide this information back to clients. So, and again, Rachel will walk through some of the ways of presenting group data and ways of visualizing that, because that you can use, standard things like, PowerPoints and Excel and things like that, easily accessible software. But so visualization is really, really important for many of our clients. They see things better than they read things. And so, I would encourage, it really depends on the platform that you're using. We to date have been stuck with our clunky EMR system. So I can't say that the way we do it with clients is particularly well. But when you look at some of the software that groups like Headspace use, where they do a lot of feedback to clients with really nice visualizations, these are the kinds of things that, if I was an NGO and I could control that space, there'd be some really nice applications. And I know that there's been some NGOs that have started to do some really nice work in this area about visualizing their information back to clients.
All right, the final question we have for the moment then is, often it's really hard for our clients to think back and remember what they've used in the past 4 weeks. How do you suggest best recording this and getting this information if we're worried that they're having trouble remembering, and particularly if they've got cognitive impairment?
Yeah, so there's many of us will be familiar with what we call the timeline follow-back approach. This was developed by the Sabels 30, 40 years ago now. It's developed for alcohol. It's a way of trying to get a structured alcohol history. And they developed, really nice ways of doing it, but it's really time intensive. To take a really structured, proper timeline follow-back approach to just alcohol use generally will take about 5 to 10 minutes just for alcohol use if you want to go back, say, the last 3 months. And a lot of it is pegging it back to important dates. So people remember things like what happened on their birthday or some important events in the last few months. So often you go back and you peg things around that. Now, we kind of say, in the training, we says, look, if you know how to do timeline follow-back approaches and techniques, if you've been trained with that, great, use it. But again, often it's really time intensive, especially when you've got to go and ask about 6 or 7 different types of drug classes. And you don't really want to spend half an hour just asking about the drugs. So again, we do recommend, don't ask about how many days have you used in the last 28 days, because that is really hard for people to sort of remember back and think about 28 days. Most people can walk through the last week. Most people. And then it depends on, again, their recall, their cognition, the extent to which you can then ask someone, and tell us about the week before that. What I often find is that you can then say, and was the week before that, was that similar to that week, more or less or different? And that's where sort of clients can then start pegging what happened in the 3rd and the 4th week, sort of to what they've been doing recently, and that seems to work where you have a fairly regular or constant pattern of substance use over the 4 weeks. My clinical impression of using the ATOP a lot is that where clients have changed things, they tend to remember that. So I relapsed 10 days ago. And then that's, or 2 weeks ago. And then you can say, okay, so in the 2 weeks before you relapse, had you used any alcohol? No. Okay, we'll put that down as a 0. In the week before that, no, we put that down as a 0. And then since when you started drinking again, which you say was about 2 weeks ago, how many days have you been drinking since then? So, with a little bit of clinical acumen and sort of adjusting it to the way that your client is responding, generally can get these fairly well done. And again, look, we all know that clients respond to our questions partly, and this is all human behavior, partly they respond according to the way that they think they should respond. And we all do this. This isn't about, drug users can't be trusted. This is just human behavior. So partly it's about how you understood the question, but it's also how the way that you want to portray your behavior and yourself. So it's why we know, for example, you can ask lots of people, so have you been involved in domestic violence? Oh, no. Now, that's not always the case. So they're giving us the response that they want us to hear. And we're well aware around things like, have you shared needles? Well, no, of course I wouldn't share needles because only a loser shares needles. Yeah, that's not, so that's kind of, so we have to appreciate that the client responses, they're telling us what they want us to hear. And that's the same for all scales. There's nothing unique about the ATOP. So sometimes it does require us to do some interpretation. Well, and by that, I don't mean change what they've answered, but sometimes go back and just ask the question again in a slightly different way. And the training manual goes through sort of the time, how the kinds of scenarios where, from our experiences of, doing thousands of ATOPs now, the kinds of questions that often we can find clients struggle with, and they often are issues around violence, child protection, sharing, injecting equipment, the kinds of things where there is sort of an acceptable social norm that most people want to see as though they're, part of the mainstream, as opposed to being, a wife beater or a needle sharer.
And I think it's about re-asking the question sometimes, but it's also, of course, about the rapport that you develop with the person that you're working with. And it's about administering a questionnaire, but you have a person with you. And so all of those things that we do to connect with our clients don't just get put to the side because we're using a clinical tool to help us. So I think that's really important for the remembering or getting responses so that people feel comfortable to give accurate responses. There's just a final comment here from Michelle Ridley to say thank you to Nick and Christy for coming along today. And we'd just like to thank all of you for coming and listening to the presentation, and also thank you to NADA for hosting us today. So unless there are any final questions that pop up, we might finish it here, and we hope to see you in 2 weeks' time when we have the ATOP Quality Improvement and Evaluation session. Nothing else is coming up. Did you have any final words, Nick?
No, just thank you. Thank you. And again, I know that for a lot of NGOs in this scenario where they're starting to collect this information, and the question is, and now what do you do with it? And so that's really where an important, it's like we collect it clinically and we know why we use it clinically, but from a service perspective, what do you do with it? And that's where I'd encourage joining the webinar in a couple of weeks' time to look at some of our experiences of how we've used the ATOP data and how you can use it for at a programmatic level. And also, again, have a look at the website because it's got a lot of resources there.
Yeah,
Thank you.
just a final question did come up. So where can we access those resources? So as it was in the presentation, so this presentation will be available on the NADA website, but the COQI webpage or the ATOP webpage is www.aodatop.org. So if you go there, you'll find all of the ATOP resources, and you can get in contact with us through there as well. Thanks, everyone. Oh.
I was just going to say, and if in doubt, you go to Google and you search drug and alcohol ATOP, or alcohol and other drug ATOP, and the web link comes up.
All right.
Thank you all.
Thank you. Bye.